I will try to explain the clinical value of monitoring pain and optimizing analgesia. In year 1993, American sociologist George Richter described what is called the Macdonaldization of our society. And he said that this idea of efficiency, calculability, predictability, and control that they impose in McDonald's shops, in McDonald's restaurants, they try to teach everyone to minimize the time required to complete the individual tasks, to quantify objectives, to create a routine practice, and to cause that the workers will appear and act the same on a moment-to-moment and daily basis. So George Richter said, look around and you will be surprised to find that you will notice the impact of Macdonaldization throughout your life. But our patients are not hamburgers, and we have to consider every one of them in a personalized view. Personalized anesthesia means that we will be able to integrate and to optimize and individualize the care to the patient. Because anesthesia relies completely, almost completely on the use of drugs. And drugs in anesthesia are very powerful and able to transiently break the most deeply rooted physiological defense mechanisms. Some of these effects are therapeutic, but others, such as unconsciousness, analgesia, or immobility, but others are side effects. And these are induced because of the relative low specificity of the drugs we use in anesthesia. So, for instance, we use usually the milligram per kilogram dosing, but this is a misguided level of personalization of opioids dosing, because as an example of the synergistic interaction between hypnosis and analgesia, and each component must be titrated individually. And there is opioid tolerance that it becomes prevalent. So opioids can create tolerance, and we have to take in consideration the size of the patient, age, surgery, comorbidities. We know that our profession, our discipline, is composed by three main components: analgesia, hypnosis, and muscle relaxation. So in 1970, our colleagues, Ali Hassan and colleagues in Boston, created a monitor for muscle relaxation, which is the Train of 4. And in the 90s, also in Boston, they created a monitor for hypnosis we usually use in our operating rooms, which is the BIS Spectral Index. But maybe analgesia is the missing link. We didn't have until today a monitor for considering analgesia, and we were working according to an educated guess. So we considered indirect parameters like blood pressure, heart rate, and others. And we know that if we use excessive opioids, then we will have side effects like hypotension, respiratory depression, post-operative nausea and vomiting, and others. And on the opposite, if we underuse analgesics, we can have hypertension, tachycardia, post-operative pain. So how do we know whether the patient has pain during the operation? So conscious patients are able to indicate that when they are feeling pain, but unconscious patients need an anti-nociception when a nociceptive stimulus is applied. in these patients, the clinician needs to rely on monitors of nociception, anti-nociception balance to be able to provide adequate, personalized anti-nociception. So if we define pain as an unpleasant emotional and sensory experience associated with tissue damage, we know that pain intensity can be assessed by visual analog scale, which is a subjective index, but all this in a conscious patient. In an unconscious patient, we only can control nociception. Nociception is an unconscious response to a harmful stimulus, what could be the equivalent for pain in a conscious patient. So this monitor we are talking today, the nociception index monitor, uses a probe with four sensors, a sensor for photoplethysmograph to look at the amplitude of the pulse, galvanic skin response, showing, for instance, when the patient is sweating as a response to autonomic nervous system, temperature, peripheral temperature, and accelerometer for movement. All these signals from all these parameters are extracted, these physiological features, calculated and normalized to the patient previous data, and also large population statistics. All this is converted into, by a algorithm, is converted into a digital number, which goes from 0 to 100. 10 to 25 is the correct range for analgesia during the operation. And here we have the colors of the traffic lights. So if we have red, a signal for more than 25 for more than 1 minute, this may indicate that the patient requires additional analgesic therapy. When null is 10 for more than, below 10 for more than 1 minute, this may indicate that we have excessive anti-nociception. We have to reduce our analgesics. We have to consider it. Of course, the correct range, as I said, is between 10 and 25. If we look at these two monitors, the null is showing that the patient has pain. He has high nociception. Even if at the upper monitor, we can see that blood pressure and heart rate are still conserved. No changes in them. So the clinical evidence of null was demonstrated in many papers and studies. When we received for the first time this monitor in my hospital, we connected it in a patient at the delivery room, and we could see an extraordinary correlation between pain of the patient by the contractions, uterine contractions, labor contractions, and even after the epidural, we could see effective epidural work. So we were very enthusiastic about this monitor developed in our country. And for instance, in a shoulder operation, we could we performed general anesthesia. This was a problematic, very complex patient with cardiac problems as well. So we connected this patient, as you can see, to the BIS, to the INVOS NIRS monitor to see the cerebral perfusion and saturation, because as you know, the surgeons are asking for this operation, which is in a bed chair position. Sometimes they are asking for induced hypotension. And then we are very much concerned about cardiac output of this patient and cerebral circulation. So, and also we connected him to transesophageal echocardiography. And as you can see here, the null at the probe for the null. And we, apart from general anesthesia, we applied a supraclavicular block. And you can see perfectly well when the null confirms the block, the efficacy of the of this suprascapular nerve block. Look at the peaks of high nociception during the intubation. At the beginning of the operation, we even gave some ephedrine. And then when the block started working, we could decrease the hypnotics and the opioids during the operation perfectly well. So the null helped validating the effectiveness of the block, which contributed to the confidence to maintain minimal IV analgesia and enabled opioid sparing. So maybe we could find in this occasion with this monitor the missing link, which is a monitor that can control analgesia during the operation. Another example I can give is during spine operations. We used to monitor spinal cord function using evoked potentials, and the technicians asked us not to use inhalation anesthetics and to avoid also the neuromuscular blocking agents. So it's very difficult to control analgesia in these operations, and we all the time we could have peaks of pain and hemodynamic instability in our patient. We started using null, and as you can see here, we can control during the highest time, the biggest time of the operation. We had more than 90% good appropriate analgesia during the different stages of spine operation. This gives us also an additional idea. We said, if null can show us in which parts of the operation the patient has more pain, so we can map the different spine, the different spine operation like discectomy, laminectomy, fusion. We can map the different periods of the operation, and we can plan better when to rise, for instance, the dose of remifentanil or other analgetics during these operations, like laminectomy or discectomy. Also, you know the enhanced recovery of patient ERAS, which is very famous, and we are trying to optimize our treatment, avoiding and sparing the dose of opioids, and trying to avoid problematic and painful things like nasogastric tubes or drains, and trying to avoid postoperative nausea and vomiting that are produced by overdosage of opioids during the operations. So here we can see a classical example of overuse of opioids when 75% of time this patient got a null lower than 10, which indicates overuse of opioids. So we learned a lot from this, and we started using lower doses of remifentanil during our operation because it's not necessary to have higher doses, and we can even build a kind of algorithm how we have to react. For instance, when we, in the past, when we were in presence of a high blood pressure or high heart rate, we explain that as the patient has pain. So maybe pain is not the cause for this hemodynamic instability. So if the null was higher than 25, this can be explained by a lower than necessary dose of opioids, and we can consider increasing opioid dose or concentration. But if null is lower than 25, we can consider giving an IV bolus of antihypertensive agent and not giving propofol or fentanyl or high sevoflurane or isoflurane to control this high pressure, because this is not the cause. Pain is not the cause. And the opposite, if null is lower than 10, to consider reducing the opioid dose concentration. And on the contrary, if we have low blood pressure or low heart rate, again, we have to look at the null and act accordingly for that. The group of Meyer and Albert Hahn, they demonstrated that you can spare 30% of the quantity of remifentanil during the operations if you control nociception using this nociception monitor. Regarding bariatric surgery, often people give drugs on the basis of dose per unit of body weight. And this assumes that clearances and distribution volumes are proportional to the weight. But these two assumptions are not valid for obese patients. So we started using for bariatric surgery the opioid-free anesthesia protocol, and we control it by null. We are not afraid to give less than necessary analgesia, because null controls the analgesia and nociception during the operation and confirms it. And even when null is greater than 25, we can still consider to give a bolus according to the protocol, and of course, if it's necessary, to move to opioid use of opioids or other drugs like ketamine, for instance. All these according to the other monitors as well, like BIS and the train of four for relaxation. So as you can see here, most of the time, 83% of the time, the patient had a good analgesia during the operation. This is a slide that I took from Schrag. They used a paravertebral block together with general anesthesia for robotic assessed thoracic surgery. And they also they combined the general anesthesia with the paravertebral block, and you can see here perfectly using null the effect of this peripheral block, that in other cases without this monitor you can never know. You can assume according to blood pressure or heart rate, but you can never be sure whether the block is working during the operation. This is an example of not robotic, but a video-assisted thoracic surgery. And again, I brought here an example of a block that wasn't working appropriately. You can see here at the bottom part the inappropriate analgesia of the patient that has a higher null that reaches 40 or 50. But then the group of Schrag, they reinserted the catheter for the paravertebral block, and then they got here, supervised by the NOL, a good analgesia during the rest of the operation. Here we can see they bring us the difference, how NOL is very sensitive for changes, and then the heart rate is only a little change. So NOL is very much specific and sensitive to these changes. And of course, we can confirm, as I said before, the regional block effectiveness acting accordingly. So these good combinations of all this monitoring, the train of 4 for a neuromuscular block, BIS to control sleeping, hypnosis, and NOL to avoid unnecessary overdose of opioids and other analgesic agents during the operation. So in our practice, we adopted this monitor. This is part of our arsenal in all the operating rooms if it's necessary. And as you can see here, we incorporated NOL at the trends of the monitor together with the ECG, the ST analysis, and the arterial, invasive arterial blood pressure. We have here the NOL, the trend during all the operation, and we can control it together with the BIS we have here and the train of 4. So NOL is in our hospital at least part of the daily practice for our operations. Thank you very much.
Thank you very much, Zeev, for your excellent lecture. It is a lecture. There are not supposed to be any questions, but can we have one or two from the audience? Or...
Professor Zeev, I would like to thank you, first of all, for your participation here in our scientific meeting. Do you know if there are some factors that can lead to incorrect measurement? So we have to have in our mind.
Factors that can affect the effectiveness of NOL?
Yes, yes, please.
Well, for instance...
Maybe temperature, maybe something else, I don't know.
Yes, people, for instance, are considering, they argued that use of dexmedetomidine, for instance, which is an alpha-2 agonist and is acting on the autonomic nervous system, maybe we will have a false positive or false negative of nociception during the operation. But we have used it, for instance, in opioid-free anesthesia, as I said before, and when the patient is having a high nociception, we can see that the NOL is high as well. So we have to take in consideration that the dexmedetomidine, for instance, can lower the values of NOL, but we have to be ready to act if we see changes in NOL, even when we're using dexmedetomidine.
May I add something? Thank you for your amazing presentation. Concerning the question from Professor Voyadzaki, I would like to add, I have limited clinical experience with NOL. I'm working as cardiac anesthesiologist, and I noticed that when we are using the pacemaker and when we start administer vasoactive drug in patients, that we have suddenly alterations in NOL value. So I think that there is an impairment in NOL values.
Correct. It is correct what you are saying. And for this reason, what we advise is to consider changes in null level only when they are for a longer period. So peaks, we can see peaks of when we give ephedrine, for instance, or a neosynephrine, phenylephrine, or as you said, the pacemaker. But these changes are short changes, short duration. And we have to consider the trend for longer than 1 minute or more, because these are significant changes that we have to react. So we don't have to react immediately when we have a peak. We have to wait and see whether this is a real change or only a short duration change. Thank you very much. I am eager to come back to the activities in your beautiful country, and I wish you good health. This is very, very much important. And send my greetings to all the colleagues in Greece.